Good afternoon. It's a great honor to contribute to the first virtual ISICEM conference. In the next 15 minutes, I shall follow on from Professor Schneider's talk and highlight the challenges of renal replacement therapy in patients with COVID-19. These are my disclosures. They have not affected what I'm going to say. As Professor Schneider outlined, there are several options for renal replacement therapy in patients with COVID, from intermittent to prolonged intermittent and hybrid techniques to continuous therapies, including CRRT and peritoneal dialysis. Clearly, it's a challenging situation, and as already outlined earlier, ideally, patients with COVID-19 and severe acute kidney injury should be treated like everybody else with severe acute kidney injury, receiving the ideal modality at the time before any life-threatening complications have occurred, at a dose which compensates for unplanned downtime, and using the optimal anticoagulation strategy. And ideally, they should be delivered by highly qualified staff in the ICU environment, aiming for high standards and quality indicators. In a pandemic, the situation is different, and it's compromised by limited resources affecting staff, equipment, and consumables. Furthermore, the treatment is often delivered by less qualified staff who also have to cope with increased workload and less training. In addition, there are challenges directly related to the disease, and in particular filter clotting and filter clogging, as outlined by Dr. Schneider. In addition to these challenges related to the illness, the team faces shortages of equipment, consumables, and staff, and has to practice in an often an unfamiliar environment where they're asked to step up and deal with less familiar situations. Adding renal replacement therapy to the situation adds additional level of stress to a team which is already very stressed as a result of physical, emotional, and sometimes ethical dilemmas. Undoubtedly, they have to work in PPE, and they are working in often in less familiar surroundings. Furthermore, the staff is requested and required to be flexible and be ready to change practice at little notice as the situation demands. And lastly, in addition to the increasing workload, there is the urgent need for training, education, and learning due to the new emerging situation. So this is difficult and a clear challenge for the team. With regard to the challenges, as outlined by Professor Schneider, the disease is a new disease and gives us new challenges. And with regards to renal replacement therapy, it's clotting and clogging, which has given us problems at the bedside. And this means that usual anticoagulation strategies often don't work, and the teams are requested and required to change their practice and step up their anticoagulation protocol and change the renal replacement therapy practice. Due to shortages, they are often required to explore alternative forms of renal replacement therapy. And patients may not be able to have continuous renal replacement therapy. An alternative is an acceptable alternative is intermittent renal replacement therapy, which obviously allows to treat 4 to 5 patients a day. It also allows treatment without being dependent on commercial fluid, provided there are either fixed or mobile reverse osmosis units available. Another advantage is the fact that intermittent renal replacement therapy does not require anticoagulation and can be delivered without need for heparin or other forms of anticoagulation. Another form of intermittent renal replacement therapy is prolonged intermittent renal replacement therapy delivered for up to 8 hours. And this, again, allows patients to receive treatment by high qualified staff. Again, in this case, up to 3 patients may be treated per day compared to only 1 patient who may receive CRRT. As an alternative, there is acute peritoneal dialysis, which uses the peritoneal membrane to remove solutes and water. For those of you who are less familiar with peritoneal dialysis, it works by instilling dialysis fluid into the peritoneal cavity, where it stays for 4 to 6 hours. And during this time, water and small molecules transfer from the tissues into the peritoneal cavity and are then drained out after a dwell time of 4 to 6 hours. This is followed by the installation of more fresh dialysis fluid, which remains inside for another 4 to 6 hours. The exchanges can be done manually 4 to 5 times a day, or also automatically using a machine which moves fluid in and out. And so the clear advantages of acute peritoneal dialysis in this situation are that the treatment does not depend on machines like hemodialysis or CRRT machines. It is independent of anticoagulation, and it does not require vascular access. And it's already an established technique in many countries with protocols and publications in place. But it does have potential other shortcomings and disadvantages. Undoubtedly, it also requires kit and fluid, it requires trained staff, and it has the potential risk of an acute leak, which may be relevant in the prone position, and the risk of peritonitis. But during the COVID-19 wave in the last few months, acute peritoneal dialysis turned out to be life-saving for quite a few patients. And here we have reports of peritoneal dialysis used in New York, in Japan, and again, another report from New York. All of these authors reported effective and satisfactory treatment with acute peritoneal dialysis. And the latter report, as shown here, more than 50% of patients had no complications during this time. And as you can see on the right, the most common complication were draining issues. The authors of this paper concluded that acute peritoneal dialysis had been successful and effective in delivering renal replacement therapy for patients with COVID-19. So there are clearly many challenges, and importantly, the challenges often vary as the disease and the pandemic progresses. To overcome the challenges, it's very important to know the team and to identify the right members of the team with the right skill mix. And this may mean reaching out to other departments in the hospital and outside the hospital. It's also essential to understand the patient population and understand their illness and identify those who absolutely need renal replacement therapy and those who may be suitable for alternative forms of renal replacement therapy. It's also vital to have an understanding of the equipment and consumables available to you in the department and in the hospital, so that the demand can be met with hopefully existing capacity. It's equally important to focus on preservation and avoiding any wastage. It's very important to prevent inefficient use of resources and preventing loss of consumables. Any form of renal replacement therapy needs to be optimized so that valid, important resources are not wasted. And in addition to optimizing the technique, it's equally important to identify those patients who no longer need treatment, so that the treatment can be stopped as early as possible and the treatment can be delivered and given to those who need it most urgently. And this may mean having guidelines in place and collaborating with colleagues in the hospital or outside to transfer patients for other alternative therapies. And lastly, team working is essential and is the most important factor. And it's team working within the critical care department, within the hospital and outside. And there are clearly important stakeholders which need to be involved. The 25th ADCI meeting focused on the management of acute kidney injury in COVID-19 patients. And one working group specifically concentrated on the provision of renal replacement therapy in a pandemic. This is the figure which was developed by the expert team, which is available on the website. I'll go through this in more detail, really to highlight the fact that this is a changing situation which demands a step-by-step approach. When renal replacement therapy provision is compromised, either as a result of an increased demand or reduced capacity, then the actions need to follow depending on where we are or where the clinicians are at the time. If still in the preparation phase, then it's important to establish guidelines, documents, and a training program to get everybody ready for a potential crisis. This also involves the securing consumables and potential stockpiling. In a crisis, the key aim is to maintain the availability of renal replacement therapy for those who need it. And again, this involves optimizing existing resources and reducing any waste, plus collaboration with partners and stakeholders. And clearly, once renal replacement therapy capacity has been reached or even exceeded, then the aim is to provide treatment and to provide the greatest good for the greatest number as best as possible. Other strategies to prevent renal replacement therapy include the prevention of acute kidney injury in general, plus optimization of non-dialytic therapies, which may include diuretics, nutritional adjustments, and bicarbonate. So in conclusion, there is no universal plan, and the circumstances may change quickly. Being prepared and flexible and team working are the key factors which will help getting through the crisis. So on my final slide, renal replacement therapy can be very challenging as a result of many factors, from the disease to supply problems and staffing issues. Being prepared and working in teams, sharing knowledge and experiencing resilience are essential. Thank you for listening.